Hysterectomy, the surgical removal of the uterus, is the second most common surgery for women in the United States. And this is after C-section, with approximately 500,000, that's 500,000 hysterectomies performed annually. The most common reasons for having a hysterectomy include heavy periods, which can be caused by fibroids, pelvic pain, which can be caused by fibroids or endometriosis, prolapse of the uterus, adenomyosis, in pelvic inflammatory disease. And we've said this many times before, up to 80% of Black women have fibroids by age 50, right? Now, reason it stands to believe and understood the connection that Black women actually are the highest recipients of hysterectomies, with us experiencing them, Black women experiencing hysterectomies 2 to 3 times more likely than white women. Let that sink in. Are you considering having a fibroid surgery? Information you need to know. Stop, share this with any woman you know battling this issue, weighing this decision, because we have some important information to share today. Hysterectomy is not the only option. It's not the only surgical option. It's not the only option, period, for helping your body end the fibroid suffering. So, our topic for tonight is red flags you should know before fibroid surgery. And joining me to have this very riveting conversation is my partner in ending fibroid suffering, Dr. P, who is, of course, I've had him on here many times. You've seen my our launch of our integrative partnership to help women with integrative options, bringing traditional and holistic practices together to help women to support their bodies and ending the fibroid suffering. So let's jump right into it. Welcome to DETOX Living, where we bring you truths, tips, and testimonials to power your toxic-free living. I am your host, Coach Gessie. I am a fibroid survivor, yes, warrior myself, turned health activist and founder of the DetoxNow.com, a holistic health platform and provider of education and supplements to help you combat the reproductive health issues, obesity, chronic disease, issues that lead to lower life expectancy rates amongst our people. So I'm going to bring on Dr. P. All right. So listen, we got a really thick conversation to have today. I'm very excited about this because, as you know, in order for people to make the best decisions in navigating the whole fibroid journey, we want to make sure they have all the right. And this started really because we had a conversation around a client of mine this week. And I was like, these things, something doesn't sound right. I was like, we need to do a consult to Dr. P. I need to get you on a consult with him, right? And it just, for me, thought about like, okay, wait a minute. What are the things, if we had to create a cheat sheet for people to kind of navigate around, hold on a second, I need to know, what are my red flags? And I did a post about it this week, and there were some things that came up that made me say we really need to dig into this conversation about what are the red flags of fibroid surgery that will help women to make the best decisions for themselves, right? And, we know that there are risks, associated with any surgery, right? Definitely with fibroid surgery, it's an abdominal surgery. However, there are things that knowing it can help you have better outcomes, period, right? To help you to make the best selection in terms of who you're working with, the right situation, the right option for your case specifically. So I thought we'd start, with the things we've already reviewed, things that we know, but I want to make sure to have them like what I call them the red herring flags, okay? Like your doctor not listening to you, right? Diminishing your voice. We've talked about this before. This is across the board, period, right? that tells you to run. The other thing, specifically when it comes to fibroid surgery, and you know, this is like your calling card. If they tell you that the only way of doing this is that you have to have a large vertical incision, run. Right? Like, look,
Big facts. Yeah, big facts.
180,
Big facts.
180. All right.
Yeah,
So
you should. It's very rarely when you should hear the only
only.
come out of our mouths. Like there's always options to do things. It might not be popular options, but you should always have options. Like if your doctor is not giving you options, that's a red flag.
Now, there's something I've heard you say around that one that I'd like to kind of bring to the fore. And it was specifically, you said, if you're able to do this through that size, you can
Yeah,
do anything. And I
absolutely.
want to put the words, I want you to say it specifically. Can you
Yeah.
share
So if
that?
you can, I mean, if you can
It
deliver a
drives,
baby,
it drives this concept
yeah,
and your standing on this.
yeah. So if you can deliver a baby through a C-section incision, you should be able to deliver any fibroid through any C-section. I mean, through a similar incision, you know, down low in the pelvis, horizontal. You know, I contend with that. I've proven it. You know, there's no reason to do vertical incisions. Again, it's more difficult. Don't get me wrong. It's more difficult. It takes a skill level to be able to do it, but you know, that's what we're for. We have to develop skill levels to, you know, maximize the care of our patients. But I refuse to believe that any you know, fibroids really deserve a vertical incision. I don't see it. So
And again, your work has proven it. Your work has proven it. Cases where people said that that's the only thing that was possible. God knows that when, you know, I turn the clock back to 2000, what year was it? One, when I had my first fibroid surgery.
they're asking UFE already.
Huh?
I
Yeah.
said they're asking about this UFE already. So
Uh-huh.
go
We
ahead,
getting
finish with them.
there. We getting
We get
there.
there.
We getting there. So hold your horses and definitely tell your other people to join. All right. So no, if they tell you that the only option, excuse me, if you are told the only option is a large vertical incision, run. You need another opinion. Another one is that the concept of, you know what, you know, we don't typically get all the fibroids. We just focus on the most important, or you know that we may need to leave them because of certain issues. Unpack that some, because I know you there's a reason you say I get all the fibroids, and
Yeah,
I work to get all the fibroids.
yeah. So I, I firmly believe, just with experience, that you know, if you leave fibroids behind, that they have just the ability to get bigger and grow.
Mm-hmm.
Now, is it possible that if you remove the fibroids, can they come back? Absolutely, anything is possible. But
Mm-hmm.
my rationale for it is that you really only have oh so long of reproductive life for every single woman. I mean, it's just a harsh reality of it. So if you remove all of the fibroids, though they may some it's possible for them to grow back, they don't have the time in
Mm.
life or the amount of hormone life left to grow to excessive sizes. And I firmly
Generally
believe
speaking,
that.
generally
Yeah, generally
speaking,
speaking,
right?
I haven't seen it. So for me, that is committed to removing each and every single fibroid for each and every patient that I perform myomectomies on. I have not seen one patient come back, and I perform
That's
fibroid surgeries every week.
that's
So
phenomenal.
I have a good sample size at this point to back my beliefs. And people that argue, I just don't have many. I really haven't met really any, but any surgeons that says, "Hey, no matter what, no matter whatever it is, I'm going to get all fibroids," and it doesn't happen. Like people really get the ones that they're most comfortable, which in fairness is
It could save
a
your life
good
if they
thing.
don't know what they're
Absolutely.
doing.
If you're not comfortable getting fibroids, I don't push any surgeon to get into an uncomfortable zone,
Right,
you know,
right,
to push their comfort levels because we're talking about people's lives at the
right,
end of the day.
right.
But if
But
you have the mentality of going in and getting every single fibroid,
mhm.
the chances of them returning are just extremely small for the reasons that I'm telling you.
So if you think about root drivers of developing the fibroids, right? And, chronic stress, hormones, like you talked about, vitamin D deficiency. There's been a lot of, research around that. Endocrine disruptors. What about if your lifestyle has not changed or has become, more aggressively toxic to the things that fuel the growth and the development?
Yeah, I mean, there's a lot of research that still needs to be done as far as that.
Hmm.
It's got to be a lot to it with Black women and
Hmm.
stress.
Yep.
Stress is a huge part, I think, of not only fibroids but advanced fibroid disease.
Yeah.
And it's something. It's a variable that it's very difficult to actually study.
Right.
You know,
Exactly.
so
But you're going to
so
study
it
every single Black person?
Right. So
Right.
it's an implied variable that we have to take into consideration, even though we don't have a ton of proof. It's just more so common sense. Genetically, there's really no reason why Black women should have,
Hmm.
more incidence of fibroids or advanced fibroid disease, but it's a fact that it happens. So we have to use some of our inferences, and when we don't know, we have to use the things that are obvious. Stress
Right.
being a huge one,
Right.
from everything that we have to deal with in this country. So
Yeah.
reducing the
In this
amount of
world.
stress, also looking at our diet.
Hmm. Absolutely.
Diet is
That's
extremely
huge.
important,
Absolutely.
but it's more so an important thing for a preventative standpoint.
Yep.
Once advanced fibroid disease has set in, it's
Once it's
very
become
difficult.
advanced, yeah. Once
It's
it's
you're not,
advanced, yeah.
yeah, it's you can't turn back the hands of time. But I say all of that to say that you can't put all of the stock on that too. I tell people all the time, I operate on vegans, vegetarians, whatever. So it's a multifactorial thing. It's not something to say.
Multifactorial.
It's
Mm,
not something to say that, I don't, if you don't eat meat, then they're going to just go away. Or if you just
right.
only eat vegetables, they're going to go away. If you only take
Right.
this particular vitamin, they're going to go away. It's a very comprehensive thing of, how you live your life
Hmm.
that impacts your overall health,
Hmm.
fibroids included.
It's definitely a matrix because even the vitamin D deficiency piece, right? So 76% of African Americans are vitamin D deficient, and vitamin D deficiency comes from the absorption. Well, the reason why we're more prone to it is because of our melanin blocking the absorption of the sun that our bodies use to convert and create the vitamin D hormone, right?
Yeah.
So that is something that inherently we're more prone to, but we're also not educated to supplement and to make sure that we're always um, ensuring that our vitamin D levels, our D3 levels, are high enough, robust, right, for our bodies to fight the inflammation and tumor. Um, Something you said about multifactorial, that's really important because it isn't just, you're right, it's not just, like there were studies around women who had traumatic upbringings, right? Like that was a specific sample, and they had more experiences of fibroids. It's in our book, End Fibroids Manual and Guide, and there was a correlation, right? So they won't say that there's direct, because when you say like it's hard to measure chronic stress, well, that's a form of chronic stress that's kind of specific versus the chronic stress that we deal with on every day, just being Black in this world,
Hmm.
right? It's more trauma, right?
Absolutely.
So, and it was connected to that. But there's trauma that we deal with on a regular basis. And when you look at the common thread of how we're disproportionately affected by so many of these issues, like, okay, what differentiates us? It's not our blood, our genetics are not different because we're Black. Our social, right, are the social determinants of our health are different because we're Black, right? So, is there any circumstance in your practice where you would say, hmm, I can't remove that fibroid. I have to leave it because it would cause more danger to try to remove it? Have you had that experience?
I've seen it.
So,
Definitely seen it.
scenarios where people say, oh, if I do this, it's going to cause you more infertility, or if I do this, it's going to cause damage to your bowel, or if I do this, it's going to. Are you proposing that that's a skill level issue?
I definitely think
That's what
it's
I'm. That's what I'm hearing. The implication is.
I definitely think it's a skill level issue. For sure, it's a skill level issue. And it's, it's your comfort. Like, if you never ran a marathon, you won't have the confidence to just go out next week and run one, right? If you never, played in an NBA game or whatever, you can't just go out and just start running up and down the court playing an NBA game. You can't do it.
I
So,
hope not.
right. So it's the comfort level. So when people say that they can't do something,
Hmm.
it's typically because they haven't done something in the past, or their experience has been bad, or misguided to the point where they're discouraged from doing whatever again. So for me personally, I've had some very difficult cases. I had a case 2 weeks ago where the actual dominant fibroid was being fed by the omentum. Ever seen this? Where it wasn't like the blood supply to the fibroid wasn't coming from the uterus; it was coming from the omentum, or the lining of the abdomen, where they had these big tortuous blood vessels. Weirdest thing
Like
I've seen.
adenomyosis? Was it?
Wasn't adenomyosis.
It wasn't.
It was just basically the fibroid had commandeered blood supply from a different source.
Source.
Hadn't seen it,
Wow.
but at that point, it was dangerous. But it's like
Yeah.
I had to just reprogram myself and just say, hey, you've been here before, you've done this, just use the things you know how to do,
You
and
just
figure out there's something that you haven't seen before, new, and figure it out. And that's happened. That happens a lot with surgery. Like, there are different variations of anatomy. No two people are the same on the inside. As different as we are on the outside,
mhm.
phenotypically, we're the exact same way on the inside. You can have a morbidly obese woman that actually is not really morbidly obese inside, is kind of actually has normal anatomy, and you can have a relatively thin woman that is like 400 pounds on the inside, and it's
That was
just,
me.
yeah. So it's like, it's everybody is very, very different, but
Right.
you have to have a doctor, or surgeons, to have the skill level to be able to adapt to different anatomy, and when they get on the inside, and not freak out when
Yeah, but
things
that
are
comes to the
against it.
fundamental skill level. It
Yeah,
goes back to
it
that
does.
conversation of the fundamental skill level. All
Yeah, it
right.
does.
So the last one is someone who is the red flag. To recap, not listening, dismissing your voice, insisting that large or vertical incisions are necessary, insisting that they need the option to leave behind fibroids, and
Hmm.
the last two, I would say, not skilled in preserving your fertility. Okay,
Right.
and because that is a huge
Yeah,
thing,
I,
right?
I, I would ask that, that's a question that I tell, not only my patients, but when I get on, I'll just say, listen, you have to ask the right questions, right?
Right.
Um, it's okay to say, hey, how many surgeries have you done where you went in to remove fibroids and ended up doing a hysterectomy, or you had to do a hysterectomy? Um, how many cases have you done where you've had difficulties with fibroids and you ended up having to leave them behind? When you get those questions and they sound like, oh man, and they can't just kind of rattle them off, or just say this is the situation in which this would happen, or what have you. Those are red flags.
Yeah, that's
How
good.
many,
I like
you know,
that. That's good because then, you're having them expose themselves, right?
mhm.
Um, and then the last one really was not skilled um, and not intentional about minimizing scar tissue, which is one of
Absolutely.
my most important conversations,
Mhm.
right? Because if they're not even talking to you about it, that means they're not thinking about it,
All
right?
right.
If they're not acknowledging it as a something that can cause you, great lifetime risk. I mean, there is always a risk of scar tissue, but then there's greater risk depending on how that person operates, right?
Yeah.
And if they're
Absolutely.
not
Like, people
acknowledging
being people being very meticulous. Ask them to take you stepwise to, like, what the philosophy of surgery is. Ask them to talk about, and people will get annoyed. I personally don't get annoyed about these things. These are very educated questions and show that you've done research and you're asking the right question and in tune with your body. Ask them, are they putting things back together again? My philosophy is, I try to leave everything like I found it. That means peritoneum, that means muscle, that means your fascia. Every single thing that I go in, I try to put it back exactly how I found it, which in turn improves healing. It also improves, your recovery, your post-operative pain, your scar tissue. Also ask about like, people should be concerned about your your cosmetic appearance, right?
Absolutely.
Like I'm extremely cognizant and concerned about how a woman is going to feel
Afterwards.
with her scar in her belly. Like, it's important to me that you have the confidence to wear a bikini, or if you're with your significant other or you're intimate with somebody, that you don't have to explain, oh, this incision or this scar or what have you. Those things are important. Like the psyche of women, the psyche of
Absolutely.
anybody,
Psychological,
it plays
major
a big first.
psychological
Absolutely.
impact. I
And
agree.
as doctors, like, globally, we tend to always think like, well, what's going to make this surgery easier? What's going to make this
Right.
the easiest thing? But easy may not mean easy for the patient. It may make it
Say that
easier
again.
for us, right? It may make it
Mm,
easier for us to technically do it,
yep.
but is it going to make it easier for her
Long
healing? Is
term.
it going to make her easier for, how she feels about her
Yep.
body in the long run? So, those are things that you want to have conversations about. And it's the things that we don't have the conversations about enough. I try to educate as many women as I can about, is this the doctor for you? Look,
Right.
damn Google reviews, damn the stuff you see on the internet, because you could pay for all of
You
those
could pay
things.
for that.
Is this the real thing
Yep.
that you're going to trust this person? Because once you go to sleep, it's over. This person is
Ooh,
this Your life is in this
in
person's
that person's
hands.
hands. Yep.
A millimeter here, millimeter there, cut
Makes a
this
difference.
way, infertility, death, like these things can really happen just like that. So you
That's
have
right.
to make sure that you're putting your hands, and I mean putting your life in the hands
Life.
of somebody that is extremely compassionate and is going to do right by you when you're not looking.
Mm. Compassionate and skilled, because you can have all the compassion in the world, but if you don't have the skill, next,
Right.
next.
Absolutely.
Diastasis recti. So that's something that happens in, many births. Is that something that happens by negligence, where
Mm.
there's the separation of the abdomen, where the muscles are now separated? And have you seen
So
that?
yeah, so it can happen. It can happen naturally, right?
Hmm.
So the abdominal muscles,
Well, first
they
explain what it is, like
sure.
more clearly.
Sure. So you have, like, most people think that like your skin, underneath your skin, everything is held in underneath your
Hmm.
skin. It's not. When women get liposuction, it's not going into like the actual cavity of your body. So you have skin, you have fat underneath the skin, and then you have muscle, right? So when you get liposuction, it's literally sucking out the fat that's between the skin and the muscle,
Hmm.
right? But up underneath the muscle, you have this thing called fascia. So fascia is like the skin within the skin,
The
or
skin within
underneath
the
the skin.
skin, like
So
the lining.
that's right. It's the skin that actually keeps your organs inside and not to the outside. So
Hmm.
your bowel, your bladder, your uterus, all those things are underneath the
The
fascia,
fascia. Hmm.
right? So the fascia, right, it holds all of those things in. So when a person has a hernia,
Hmm.
it means there's a breach in the fascia, or there's a hole or a weakening of the fascia. So
Hmm.
like when you see somebody have a belly button hernia, or a hernia down in their groin, or a hernia in the midline of their belly, that means that the fascia has a breach in it, and the inside world, which are your usually your intestines, are now pushing through that hole, and
Bulging.
now you can see it on
Bulging.
the outside skin. It's
Hmm.
bulging for now that you can see the outside skin. So that's what a
Okay.
hernia is.
Hmm.
What diastasis recti is, the muscle that's on top of the fascia is usually connected on in the midline like
Hmm.
this.
And it starts to
When
separate.
there's a separation of the muscle, now
Hmm.
things from the inside, it's almost a herniation of the muscle, which is what it is. It's when the
Right.
muscle herniates, and
Great
now that
description.
then that's when the fascia actually can bulge, and everything will start to bulge because the muscle is not supporting the fascia like it should be. And so
Have you
with
seen that
that,
happen because of botched fibroid surgery?
Not so much. That's where it gets kind of
Birth.
it gets kind of sketchy. I wouldn't say it's not botched because um, we're taught as surgeons that the body really like the muscles kind of like sit back into the midline on their own even after surgery. So for most of us surgery wise, we're not really taught to reinforce that muscle. So if
Mhm.
you go in
So it's
for a
supposed to
surgery,
normally reattach.
normally
Okay.
reattach.
I'm just giving
So
them
it's
layman's terms.
especially for um, women that have large masses, i.e., fibroids,
Hmm.
i.e., pregnancy,
Pregnancy commonly.
where it's really pushing against the muscle, pushing against the fascia, and pushing it out.
Hmm.
Typically, when all of that comes back down, the muscle will adhere back together. But again, everything is multifactorial. If you have weak collagen, if you have like smoking history, chronic lifting, genetics, all of those things kind of play into it to where women can have a weakening to where that muscle
And it
attaches and
doesn't
it can bulge
reattach.
out. What I
And see,
personally do to counteract this is whenever I perform surgery, you have to go in that midline and separate the muscle to be able to get things out.
uh-huh.
I don't rely on the muscle to be able to naturally adhere, even though it should, back together. I reinforce it and I suture it together so that as it heals, there's an extra layer of strength behind the muscle. Now,
So,
again,
but that's
a,
intentionally.
that's very intentional. But again,
Yes.
a
Hmm.
woman that has a vaginal delivery where nobody goes into her belly, she can have
She can
diastasis.
still have diastasis
You can still
recti.
have diastasis for people that are morbidly obese and that are pushing out, and there's a weakening of the muscle. So diastasis can happen naturally.
Yes.
The argument is that we can also be the initiators of diastasis by separating that muscle and
Right.
not placing it back. So I make a habit of anytime I'm going to the belly, if I'm separating it, I'm putting it back together again like I found it. So it's
All
kind of,
right.
it's not to say a surgeon actually caused it or did
I
it, but
understand.
they could have reinforced to help counteract or prevent it.
Something
Because
they could do. It's
that's all it's
knowledge.
done. Right. That's
Right.
all it's done after the fact to rectify diastasis is literally just putting it back together,
Suturing it
just
back
putting the
together.
muscle back together again. That's it, putting
Right.
permanent suture into it.
Right. Okay, so we're going to dig into the meat of it. So last week, as I said, I posted about red flags. We posted together on that.
Mhm.
And I thought it would be helpful to review the types of surgeries available for fibroids and specifically go through the red flags for each one. The UFE came up in our comments, and I thought let's just put it right at the top of the list and dig into
Let's
it.
talk about it.
Let's talk about it, right? And because there are a lot of problems with it. So, what I want you to think about and I'm talking to the audience right now, y'all, our community, really, community and tribe, is that when you hear about these procedures, I want you to think about, okay, these are the things I need to know off the top, the flags concerning it, and also
Mhm.
where it is. I would say the red flags and also the benefit, like the key benefits, right?
Absolutely.
So let's dig right into the UFE, red
Mhm.
flags, and if there are benefits of the UFE.
Yeah. So first and foremost, I mean, to even piggyback off of that, when you talking about any procedure, another question that you want to ask, like your surgeon or whatever, ask them, would you do it to your mother or would you do it to your sister? Right. That honestly, that's what you would want to ask. And so for me personally,
So would you
as
recommend this for your mother? Mm-hmm.
absolutely. What would you do? Well, yeah, let me not say let not operate on your family, but before we get into that whole
No,
goddamn
let's
thing.
not do that. See
But
how I helped you there?
yeah,
See how I
thanks.
helped you there?
But I don't care what nobody say.
I know. I'm just
I'm
looking
protect
out,
mine.
brother. Just looking out.
I
Just
know
looking
I
out.
got it. They can say what they want. I'm protect mine. My sister just told me today. She was like, "Hey, when I had this next baby, listen, I don't care what nobody say, so it's
Come
fine."
on, sis.
Right.
Forget all that. So, somebody just asked, and
So
this is a really good question. They said, can you have a UFE before a myomectomy? Why?
I wouldn't recommend it.
Oh, uh,
I wouldn't recommend it. So back to what I was saying. So I personally don't recommend myomectomy for my patients or my family. I would not. And these are the reasons why.
wait, you
Okay.
said UFE. You said myomectomy. you personally do not recommend myomectomy, or you personally do not
I'm saying
recommend?
that's like myomectomy. If I'm
Yeah,
misspoken,
that's
excuse
why
me.
I want to
I'm sorry.
correct
I'm
it so
sorry.
we
I'm
get
sorry.
this
Excuse me.
right.
I'm sorry. I'm sleeping. Long day. So I would not recommend UFE
Mm-hmm.
for my family or my patients, and these
Mm-hmm.
are the reasons why. So
Okay.
what a UFE is a UFE is a minimally invasive surgery in which a
Procedure. It's not really a surgery.
is
Procedure.
correct a procedure. It's tomato tomatoes. It's a minimally invasive procedure in which a interventional radiologist, not a gynecologist,
Not a
but
gynecologist.
it
Not a
but
surgeon.
an interventional radiologist will basically scan with an
Mm-hmm.
ultrasound scan of
Mm-hmm.
your fibroids and the blood and the vasculature that's going to the fibroids. They're going to track or trace the blood vessels, and they're going to go through large vessel or large artery either in your
Mm-hmm.
leg or in your arm, and to go
Mm-hmm.
in. They're going to inject an agent that's going to basically clog the artery that's feeding your fibroid.
Let's call them spheres. Particles. Spheres are what they are, right?
Yes,
Which are not organic material.
correct. And what this is doing
Let I want
is
y'all to
it's causing
understand what that means. Not organic material.
it's not
What does
organic
that
material.
mean, Dr. P?
What not it's
Non-organic,
man-made, it's man-made particles, okay,
man-made
that are
particles.
going into your blood vessels to basically clog them off. Now what that does is it causes something called ischemic necrosis. It's cutting off the oxygen, the
Mm-hmm.
oxygenation. So when you block oxygenation, it's called ischemia. So for instance, if you sit on your hands, put them under your, if you are on your toilet, just sit on your hands or just sit there for too
Or
long
your
and sit on
chair.
your
Mm-hmm.
legs.
Mm-hmm.
Think your feet will start tingling, your
Tingling.
fingers will start tingling. That is a lack of oxygen is getting to your
Mm-hmm.
extremity. When you
Mm-hmm.
get off the toilet or get off your hands, the tingling goes away because the
Mm-hmm.
blood returns to it.
Mm-hmm.
Imagine if you cut off that blood to living tissue and the
Mm-hmm.
blood does not return.
That's right.
That can cause chronic pain. So for
Mm-hmm.
me, in my experience, I am not saying or discrediting UFE for any person that has worked for us because I'm not going to tell you that it does not work at all.
Mm-hmm.
However,
Oh, they can not work.
if you give me, or I've seen
Mm-hmm.
multitudes of people that have come to me after UFE,
Mm-hmm.
an overwhelming majority of those patients that come to me with UFE have pain and are still complaining about issues and now are having post-operative surgical or post-operative procedural pain or
Mm-hmm.
UFE type pain
Mm-hmm.
from this ischemic necrosis.
Right.
That's one huge reason
So
why I'm
pain,
not a
increased pain.
proponent.
Mm-hmm.
Increased pain from it, and it's just not very effective because if you do have a fibroid that's causing bleeding and it's pushing into the cavity of the uterus, you're still going to have that mass or object that's pushing into the cavity of the uterus, and it's still going to be giving you problems.
Yeah, the
So
fibroid
for the
doesn't get
people,
removed. So that was
fibroid,
the
I get removed.
description of the procedure, right? And let me just tell you,
Correct.
in my personal case, I had the UFE after I had my daughter. Not again, I was not doing this work. I knew nothing about this. Fast forward to wow, why did I do that? But the point
Mhm.
is that I didn't have pain from it. However, fibroids within like a year tripled in size. I went through like a very stressful period in my life, and whereas they were just kind of like dormant before, they
Mhm.
literally grew massively, like they were on steroids, right, and became very problematic. This is post the after I had my daughter, right? After the UFE, they grew ridiculously. So the idea that they cut off the supply, and it looked like, quote unquote, it worked at first. A year later, it didn't, right? Because here there
Mhm.
were fibroids were growing massively. UFE, UAE is the same thing. People try to act like that's uterine fibroid embolization,
Same thing.
uterine artery embolization. This is broken down in detail in my book, End Fibroids, because we're not going to be able to go into every single procedure, right? This is the book. It's called End Fibroids, Manual and Guide to Help End the Fibroid Suffering. Now, here's the deal, right? Key red flags when it comes to UFE. You just said, number one, you could have increased pain, right? Number two, he just said it doesn't actually remove the fibroids. But those are two big things, right? So if you're dealing with massive fibroids, advanced fibroid disease, let's call it that specifically, because that's how we've been referring to it, right? And such as you're dealing with heavy bleeding, like to the point where maybe it's very distended, you're dealing with severe pain, you're dealing with bleeding that's causing you anemia on a regular basis. Again, it's supposed to cut off the blood supply to it so that it kills it, right? But also those particles can travel other places. They can travel to other places in your body. There's no like way of controlling it specifically to keep it from doing that. But then also it doesn't cause the fibroid to completely be removed, right? So as I said in my case, they became very problematic a year later. Another red flag though about UFE is fertility, right? Like in terms of its impact on fertility. For a while, there was research showing that there was increased rates of miscarriages connected to it. What do you know about that?
I mean, the literature is still very mixed. I mean, there are,
Right.
when you have patients that have gotten pregnant after
Yeah,
UFE,
there are.
you can't necessarily say it causes infertility.
Right.
So it's still a fertility sparing procedure. But to back to the point of, the other causes, when people talk about UFEs, the question to ask them is like, how many patients have you operated on that have had UFE? Have you ever looked at a fibroid or felt a fibroid or seen a fibroid that has actually had a UFE change or has been through a UFE? And
Mm-hmm.
then now, if that does not tell you who you should listen to, I don't know what else does. Like, because I actually had an argument, not argument, but a back and forth discussion
Mm-hmm.
with an interventional radiologist over
Yeah.
social media, and he was
Yes.
telling me about,
Like
UFE
it's
and
a
his
silver bullet.
experience or what have you. Yeah, his
Mm-hmm.
experience, but he's never operated on a fibroid before. So
Mm-hmm.
on my page, I actually show I talked about UFE and my opinion about it, and I showed a picture
Mm-hmm.
of a UFE fibroid in my hand with ischemic necrosis and what that looks like.
Does it look
And so
calcified? Does it look like?
it looks different. It doesn't look the same always. In the
Mm-hmm.
particular case that I held, it looked like uh, a big
Like this is
shell, a
your
big
lung on cancer?
shell. It was a bowl like that looked like chocolate pudding, if you will. And it
Mm.
was from it's or like a maroon colored chocolate pudding, and that was just the necrotic
But
tissue that it
how
cat
does
that it
that not
liquefied.
affect the rest of your health?
It
Like
can. It's
to have
called it called
something dead on the inside, is
Yeah,
it
for that
your
woman, it caused extreme pain. It caused, extensive pain. When you don't have blood supply to tissue, it can cause pain and necrosis,
and then
so
what happens to it over time? Is your body
your body can what's called phagocytize some of the material, meaning that it can
absorb?
uptake some of that or
Mm-hmm.
absorb some of that material.
Mm-hmm.
But other time it's just going to stay there. If it's in a shield or walled fibroid, it will just sit there, and then that will be a part of your body
In your uterus.
causing, yeah,
So
causing whatever pain or discomfort that it may cause.
have you seen a scenario where someone had advanced fibroid disease where they were having very heavy, very severe symptoms, and the UFE actually um, ended their suffering?
Well, I'll take that back. I don't see it in advanced fibroid disease. Anybody that has said UFEs work or are helpful usually have smaller fibroids,
Mm-hmm.
4, 5, 6 centimeter fibroids,
Mm-hmm.
nothing much larger than that. If you have
Mm-hmm.
advanced fibroid disease, meaning you could take your hand on your belly and you push down and it's hard and you can
Mm-hmm.
feel masses in your belly, that's
Mm-hmm.
advanced fibroid disease.
Right.
So I'm telling you exactly what advanced disease is. It's
Yep.
fibroids that are 10 centimeters and
And
beyond. It's
beyond.
fibroids
Mm-hmm.
that are actually palpable
Yeah,
on
that's like the size of
on
an
the
orange,
abdomen.
10 centimeters,
Right.
like an
So
orange, a large orange.
it's fibroids that are actually palpable. When it gets to that point, UFEs, I don't see them being effective at all.
Mm-hmm.
It
Okay.
causes more pain than good.
What would be the case where there would be a benefit, if there is any, in getting the UFE.
So there will be a case when a person is not medically stable enough to undergo a more extensive surgery, right? So if
Correct.
you know if you need a very, very minimalistic procedure in which you don't have to undergo
Cut.
extensive anesthesia
Hmm.
and be have a more extensive recovery, then UFE would be more beneficial,
Well, it
i.e.,
could be.
patients
It
could
could
be.
be. We don't know that
It
it
could
would
be,
be, right?
but it's better than nothing. So if that's your only option to do, I would say, do that as opposed to
Well,
absolutely do nothing.
what would make that the only option next to, the next one,
Well,
which we would say like,
some people, sorry, so for instance, if a patient you know, has had, you know, multiple comorbidities, hypertension,
hmm
diabetes, morbid obesity, strokes. I mean, if they had an
hmm
extensive medical history and were not candidates for surgery,
hmm
and they could not take, and if they had like a stroke history or hypertension and they could not take like hormone suppressant medications,
hmm
then that would be a minimally invasive approach to try to help control it. It's other instances like when women um,
oh, and
have
let's not
had,
forget lifestyle changes that could help them control the suffering in terms of the symptoms.
yeah,
But we're talking about
yeah,
also
just in acute
acute
states,
situation.
right? In acute situations where a
Hmm.
patient does not, their health, eliminates other options.
Okay. Well,
It
would an
becomes a better
assessor
option.
be? So I was going to go to the next one, which is like
Hmm.
the assessor, right?
Hmm.
In that case, depending on what their surgical history is, the assessor may not be an option. Is
It
that?
may not be, and so for everybody, what Excessa is,
Hmm.
it's
Now, is it
it's
accessor or assessor? I've heard different. I heard assessor. Is it accessor? Am I saying it wrong? Because I've heard assessor.
Excessa, right? So
Accessor.
yeah,
Okay.
ACESSA.
Hmm.
So it's a C in there, but
No, I know it is,
the
but I thought it was
the
pronounced softly.
Excessa,
Okay.
like with a like access, Excessa.
I guess like access.
Um,
Hmm.
yeah, access. So what the difference between Excessa and UFE is that instead of actually cutting the blood flow to the fibroids, the blood flow still goes. It doesn't cut the blood flow, but it actually treats the actual fibroid. So
Right.
it provides a radio
Mm.
frequency ablation or heat
Heat.
to the fibroid, which
Hmm.
causes the heating of double bonds, which breaks double bonds, which now softens the tissue, right? So it doesn't cause an ischemic necrosis,
Hmm.
but it causes a denaturing of proteins or a breakdown of the intrinsic structure of the fibroid to now make it softer. So changing it from like a baseball to a marshmallow,
Hmm.
which
Your body
which
can more easily
right,
absorb, break down.
your body can deal with this better, and it does
Hmm.
not cause the excessive pain because the tissue is still alive, it still have a blood flow,
Hmm.
but it is in a completely different composition. So for symptoms like pain with sex, frequency of urination, excessive pain with or cramping with your bleeding, it's basically the mechanism is the uterus has a large hard mass that is trying to cramp around, which is causing that stuff. Or in the
Hmm.
case of sex, if you have a fibroid that's sitting
It's the
low on
where's
the
location.
uterus, and
Yeah.
you're and obviously you can think about what that is. Or if a fibroid is
But
pushing on a bladder,
how is accessor gonna stop that? Because all it does
right?
is soften it, right?
Correct. So if you are having sex with your husband,
Hmm.
and instead of him poking on a baseball,
He's poking on a
poking on a
marshmallow.
marshmallow, it's
Hmm.
different
Yeah.
pain wise for you.
Hmm.
Or if it's pushing on your bladder,
Yeah.
now that the bladder
It
is
release
trying to
pressure.
right, instead of the bladder trying to expand on a hard mass and it not allowing it to expand, now you have a softer mass and it's now allowing the bladder to expand, which will treat the frequency of urination. That's what excessive does. And the reason I'm a proponent is because it's very effective at treating the bulk symptoms. And it also doesn't cause this post-operative pain syndrome because
Hmm.
it's not dead tissue that's inside. It's just tissue in a different um, character or composition, if you will.
So you just really talked about the benefits, right? Just
Sure.
now. what
Yep.
would you say are the red flags?
Um, red flags are, well, no, I wouldn't say so much red flags. I would say the things that you have to be realistic about. So if you are a person that is, your sole focus is to get your six pack back because the fibroids are
That
protruding
ain't
your
gonna be it.
abdomen,
Yeah.
it's not going to
That ain't
happen.
gonna work.
It's not happening well. So you're going in with the proper expectations.
Right.
Another major one is, bleeding.
Hmm.
So, you know, the misconception is that if you have excessive bleeding and you have fibroids, that the fibroids are causing the bleeding. And that's not always true. And oftentimes it's not true
Hmm.
because you can have two women, same age, same demographics. One of them has fibroids, the other one doesn't have fibroids, and their bleeding profiles are exactly the same. And
Hmm.
what that will tell you is that fibroids don't always cause bleeding.
Hmm.
So if you're going in to do a UFE, even a myomectomy, just to remove fibroids, just for bleeding, it's a strong possibility that
Hmm.
you may just have heavy bleeding and have
But
fibroids.
it
And
could,
removing the
again, it
fibroids,
can be connected to hormonal imbalance, which is why
yeah,
we
that's
say
exactly.
tackle. Let's look at the things you can tackle lifestyle. Like, in our prevention kit, in our fibroids kit, we deal with the things that we can change on our own. We can deal with hormonal balance. We can deal with a nutrition plan that helps that. We can deal with vitamin D deficiency. We can deal with chronic inflammation. And then now you're saying, okay, well, what's left? Like, what else is my body needing to tackle, right? That I can't tackle on my own for those who want to go that route. But what you just said about the accessa, let's go back to the accessa, excuse me, is that if you are wanting for them to disappear, right? Meaning wanting the fibroids to not be there physically, that's not the
That's
option
not
for
the
you.
surgery for you.
That's not
It's not.
that's not the solution for you, right?
Correct.
Because it's
It's an
not
option, but it's just
surgery,
not it.
it's a
Right.
procedure.
Right. What,
But
excessive? No, excessive surgery.
well, oh yeah, there are. You're right, because there
It's a
are
surgery. You have
incisions.
to go. You
It's
have
a
to
it's
go
a
under
minimally
general
invasive.
anesthesia. You got to go
Yeah, yeah,
into the
yeah, yeah, yeah,
belly.
yeah,
It
yeah.
is
You're
a
right. It's
surgery for
minimally
sure.
invasive. Of course, you know this. I'm sorry,
Yeah.
but
Yeah.
what I was gonna say though, so if you're looking to preserve your fertility, it's a benefit. It's still a good option. If you're looking to do something minimally invasive to help advance your specific journey, it could be an option for you. Where
Mhm.
have you seen, like, if somebody says to you, wait a minute, they're offering me the accessory, you're like, not in your case. What would those cases look like?
If you have very, very large fibroids, or if you have very, very large fibroids that are pushing into the cavity as well, Excessa is not optimal for you. Excessa
Yeah.
is for women with manageable fibroid size. And even if they're pushing into the cavity, I would also recommend anytime I do Excessa, also do hysteroscopic check. So I'll take a camera, put it into the cavity of the uterus,
Hmm.
remove the fibroids that are out of that are in the
In the
inside of the uterus,
cavity,
or the
intraca-
portion of the portion of the
intracavitary.
fibroids that are pushing into the uterus. Because very rarely are fibroids completely in the cavity of the uterus. Usually there's a portion of them in the muscle and a portion of them pushing into the cavity. So you have to remove the portion that's pushing into the cavity and then go up laparoscopically and treat the portion that's in the muscle.
What about the scar tissue that can actually form from the hysteroscopic procedure that can become an issue with the attaching of an embryo?
Um, as far as like how to avoid it, or as far as like
Yeah,
what do you
yeah.
it's not really what you could do to avoid it. I mean, if you unless you do an extensive um you know, procedures into the uterus. And, with Accesso, you try to avoid burning to the cavity,
Mm-hmm.
which is why
Yeah.
you try to remove the portion that's out of the cavity, out of the
Mm-hmm.
cavity. Um, but scar tissue is one of those things like in the cavity that's very it's difficult to control. But with that being said,
Yeah. Yeah.
it's not a very typical thing where you undergo like a hysteroscopic procedure and end up with what's called Asherman syndrome, or
Hmm.
extensive scarring into the cavity into where you can't get pregnant.
Okay. Again, so there's a lot more procedures. So I think we're gonna have to do this in parts because
Uh,
because I like how we're doing this. we're not just kind of doing the top line, ding, 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 right?
Yeah.
We're really getting into it. So I want to probably wrap it up with, maybe we'll separate this into invasive versus minimally invasive, right?
Okay.
And there's the ablations, like there's but that is the laparoscopic assisted, how
You
do you
said
say?
lamb?
Lamb, yeah, the lamb.
What's that? Laparoscopic assisted myomectomy?
Yeah, lamb. That,
Okay.
I'm sorry.
Yeah, I
You all
think that was
call it
a memo.
lamb. Yeah,
Yeah.
okay.
So yeah, we got to look at, like, you got to go through some of these. They're asking some pretty good questions
Okay,
in here too.
so
So
why
we
don't
need
we
to just
stop
go
here
through that.
and answer some of the questions? Is a C-section birth mandatory after a myomectomy?
Yes.
Actually, you say yes?
For me, yes. All right, look at it this way, right? And you'll see the literature if it says, you know, if the fibroid is subserosal. Well, if it's subserosal, yes. But if it's
Yeah.
pushing,
Subserosal.
if it's pushing into the
Subserosal.
muscle of the uterus, right? It's
Mhm.
push and that's for me. So for instance,
Well,
if you have,
subserosal is on the outer
it's
lining
on the
of the uterus.
outer lining of uterus.
Hmm.
With that being said, if you have the same surgeon that's performing your myomectomy, and that surgeon determines that you may be able to deliver vaginally, and they deem that your fibroid surgery was not very extensive and that you would be a candidate for it, that would probably be the only scenario in which that would happen. But there's not a surgeon, at least I know, I'm not going to do it, where you come to me and say, I've had a myomectomy and I'm going to allow you to
Yeah.
deliver vaginally. I'm not going to do it because I have to take
The
someone's
rupture,
word.
the
Yeah,
rupture
I
of the
take
uterus
somebody's
is
word
just
that they
too much,
didn't. It's
because it's
way
a
too
risk.
high.
Why do it? Just
It's a
why?
huge risk. So,
Huge risk.
for instance, right now, and people get hung up off of risk and benefits and those types of things. And let me put it to you this way: we get on planes and we get on flights, and there's a risk of that flight crashing or never getting there, but we do it because that risk is so very low. It's 1 in a million that the benefit of us getting to wherever we got to get, we do
Right.
it. There's a risk that anytime we get into our
Every
car,
flight,
we're not going to make our
every
destination
car.
in a car,
Yeah.
right? But we get into our car, we go home, we go to work, because the
Yeah.
risk of an accident and us not getting there,
Hmm.
right, is extremely low. It's
Right.
0.00 something percent. But when I tell you that the risk of you delivering vaginally after a myomectomy is a 4 to 6% chance that either your baby will die or you and your baby will die,
Not gonna do
that
it.
is a very high risk.
High
And so,
risk.
with that being said,
Yeah.
you nor your surgeon or OBGYN should be comfortable with taking that risk. Can it
Yeah.
happen?
Yeah.
95% of the times it will, but 5% is
That's
way too
too high.
much to take that risk. So that's why it is strongly recommended that you have fibroid surgery to undergo a cesarean section. Now, if you read the literature, it'll say, well, yeah, if it's
You mean
on
you
the
have a
surface of the
C-section
uterus,
if you've
yeah, I mean,
undergone
have a
fibroid
C-section.
surgery?
Yeah, C-section. If I misspoke, excuse me. But
Yeah.
if you have a fibroid that's on the that's on the external portion of the uterus, and it was a very simple myomectomy,
Mm.
possibly. But
You mean
again, this
like
is
if it
very rare.
was pedunculated
If it's pedunculated, yes. If it's straight pedunculated, meaning that it's a very a small stalk
on the
and the
stem,
fibroid
a
is
stalk?
hanging off a stem of the
Hmm.
uterus, and it just clip the stalk and remove fibroid, for that, yes, you can
Right.
deliver vaginally. But that is very
What about
rare.
hysteroscopic?
Hysteroscopic myomectomies are different because it's not really compromising the
Right.
integrity of
So
the
I'm saying
muscle of
these are
it.
scenarios where,
Yeah.
okay, that the
But
risk is
but the
not the
but
same.
the caveat to hysteroscopic myomectomy is that, if you just do a hysteroscopic myomectomy, then chances are there's still a larger portion of that fibroid that's still in the muscle, right? And we grade fibroids on FIGO scores, right? So a FIGO 0 is literally when the fibroid is pedunculated the other way, meaning that
It
instead
comes on
of
the
on the
inside.
outside of it, it comes on the inside and
Hmm.
stalked off on the inside. It's
Intracavitary. It's
correct.
intracavitary.
It's very rarely that
Ventilated.
that's the case,
Hmm.
right? Chances are, if it's in there, it's somewhat embedded in the muscle and also protruding into the cavity. And
Hmm.
so you can get the portion that's in the cavity hysteroscopically very easy. It's getting the other portion, because if you only get the portion that's in the cavity, it's a lot of times that that rest of it will start to herniate over time and still be in the cavity over time, you know,
And
so you
likely
have
will
to
grow
just,
during pregnancy because of the hormones in your body, right?
yes.
Um, so what if, question, what if the surgeon wants to make two incisions, one horizontally in my bikini line and the other one through my belly button? Is that normal? No, that's not
No,
normal.
what is, I
So,
mean, I don't understand why they would do that.
well, T-strap. So, okay, the T line was,
The
um,
T, we said
if they
one in the
started
belly,
with a
just in the
bikini,
belly button,
huh?
started in the bikini and then went up like a T incision, like that.
Yeah, yeah.
Oh
And
my
so
God.
the scenario is where they say, "Oh, I've heard this scenario, right? Where
I've
it's,
heard it.
oh yeah, we're gonna try to do it through the C-section. Maybe it's a second myomectomy. We're gonna try to do it through the myomectomy, through the C-section bikini cut that you had before, right? But not C-section, but the bikini cut. But if we can't access them this way, then which is a skill level thing, then we'll have to cut you vertically."
So if you talk to a surgeon and
And
they
they
tell you
say that,
that, you
run
walk out the door. You get your stuff in the mid sentence and you walk
sorry,
out the damn door.
like that.
Period. You walk out the door. You
Period.
tell them I said so. Walk out the
Period
door.
on that. Period on that.
I keep it 1,000% like with you. Like I'm the person that they shouldn't have let into med school because I'm gonna tell y'all how it is for real. You know, everybody will sugarcoat it, and I'll tell you when doctors are bullshitting you, or you going in and you like they shouldn't be telling you stuff, or they telling you stuff that doesn't make any sense. I'm that guy,
Yeah.
and it's certain things that when doctors say or surgeons say, and I know it's trash, and they can make it sound really good to kind of sound good to you, but it's a lot of garbage. It's a lot of garbage, and you have to understand what garbage when you hear it.
That's
That's
right.
garbage. Don't ever let nobody tell you they need the T incision. I'm not T incision nobody. Should not
No.
even have to T incision anybody for nothing.
Someone just said, if a doctor starts getting annoyed with your questions, annoyed because you're asking questions, that's a red flag. Gotta go.
I don't.
Gotta go. That was
It's
number one.
painful. It's painful as it is to answer some of y'all questions. I got patients. You'll get mad because I'm late coming in to you, but you don't realize the 1,000 questions that you ask you making me late for somebody else. You know, so and you will ask the same question about 80 times. As annoying as it is, I will sit there and answer every single question that you have.
All right, so we're gonna call this part one because I feel like we can dig into this way more. We haven't gone into endometrial ablation, laparoscopic myomectomy. We haven't even really touched myomectomies in detail,
Yeah,
robotic, all of that. So I want to do a part two on this.
I'm very opinionated about that
Yeah, I
as
know. That's
well.
why I'm saying we'll make that part two. We're probably
Yeah,
not this week because I have another one, but maybe the week after. We'll see.
no problem.
Your schedule is so crazy,
It
but
is, but this is good. This is good information. I hope everybody got something
yeah,
from this. You know, so yeah, I hope this is good for everybody. So
yeah, yeah.
we'll see the feedback, and however you guys want us to kind of tailor the conversation, as you let us know, we'll do that.
Absolutely. Put it in the comments so that we can use that for next time. But we'll definitely post this so that you can refer to it. And again, I worked hard on this book, End Fibroids Manual and Guide, so y'all had all this listed out in one place because I know it wasn't available for me when I was looking. So that you can then say, wait a minute, come to the say, well, what about this procedure? What about, and then a lot of times, like, well, if they don't really know how to do any of the other ones, isn't that also a red flag?
Absolutely, yeah. People just not comfortable doing it. It's a red flag. I mean, it's not. You know, like I respect surgeons that will say, "Listen, I'm not comfortable. Let me send you to somebody else." I respect that.
I respect that.
It's the ones that will say this is your only option because this is all I know how to do. If somebody tells you this is the
Well,
only
well,
option,
will
they
they
don't know how
say
to do something
they
else.
may not say this is all I know how to
No, they
do,
won't. But I'm
but
saying I'm
how would
implying
it
that
show
if they
up?
say
But
that.
but
Yeah,
but let
it's like
how would it
yeah,
show up?
it shows up like saying this is what you have to do. You have to get a hysterectomy. You have to give a hysterectomy. That means I'm not comfortable doing myomectomies or the other things. You have to get a vertical incision. That means I'm uncomfortable with giving you a bikini type incision to preserve your your
To
confidence about your
recovery,
your body and
improve
your
your
recovery.
recovery, preserve your psychological and your physical thinking about your own physical appearance, all of those things. Those
All
are
of the
very
above.
important. And your recovery. I mean, it's more to recover from. It's more risk, right? It's more risk,
Huge,
more cutting, more risk.
huge. I mean, and you can speak on it. I mean, you've been through it, so you know.
Continue to every single day I
Right,
manage around the risks
right.
around all the several surgeries I've had. So,
Yeah.
all right. Well, thank you so much for this. Again, always, we're going to continue having all of these. Let me come back to saying the reason I have these conversations with Dr. P is because, remember, there's a reason I said that we formed our partnership in terms of to help people with ending fibroid suffering through an integrated and holistic way, because I've never partnered with a surgeon before, but his skill level and his commitment to actually deliver on what he actually stands on is unmatched. He likes to say one of one, and I agree with that, right? Is one of one. I've talked to and I've spoken alongside a lot of physicians. And not only I don't hear people saying these things, I don't see people proving them with their cases. All right. That's why you will see me share his content and specifically talk about it and have these conversations. My thing is, you know what? Book a consultation with Dr. P to at least see what's going on with your case, because if he recommends that, just this recently, it was a client just this week. He said, you know what? No, it sounds like she's on the right path. What she needs to do, what she's doing is what she needs to do. And for me, that was big, because he's not like, oh, hungry for surgeries. He ain't hungry for surgeries. That's for certain.
That is for damn sure. I'm not. I am booked up. Listen, and what I've realized now is like I got to stop doing multiple of them at a time. I cannot. Like I was in there like 6.5 hours. Six. No, I was like 6 hours. 6 hours yesterday, struggling to remove 13 pounds worth of fibroids, and it does like now it's like it's doing something to my body to
It's
where it's
affecting
like
your body.
all I could do is come home and
You
just
got
like
to give
pass out.
yourself rest and recovery time,
Yeah.
brother.
So
Yeah.
it's I have that in abundance. It's like they
Mm-hmm.
are starting to pile up. So
Yeah.
trust me, I am not
Yeah.
clamoring for people to come to me for this, but
No.
I'm doing it because I hate to see my people, my sisters, have to go through
Yeah.
subpar treatment and not have their options. So I'm gonna continue to do it as long as
Yeah.
God continues to bless me to do it.
Yeah.
But don't look at any of my stuff and think that I'm like, hey. It's not that. I
No.
literally, genuinely care about you all's health. And I'm
Yeah.
sick and tired of watching and hearing women go through torturous
Yeah.
surgeries and recoveries and not given
Recoveries.
the options and having to be forced to get hysterectomies that they don't want. It
Mm-hmm.
aggravates me and it angers me to no end, which is why
Absolutely.
I do what I do.
Yeah. And I mean, the reason why I do what I do is because if what I've been through in my life, I don't want you to go through
Absolutely.
it.
Yeah.
That's why. That's
Yeah.
why. That's why we work together to do all of this stuff. That's why I
Yeah.
pull together all the programs and options, because I wish I had the solutions available now. And I want you to know about all the solutions that are available for you, right? And the other thing that I appreciate is that Dr. P is not going to tell you you need surgery if you don't need surgery, right?
Absolutely. I have zero,
That's
zero.
zero reason.
I
All
have.
fibroids do not require surgery. And
I
again, that's
say it
why
again. Say it again.
all fibroids do not require surgery. So please
Facts.
take the quiz at the link in my bio. Visit the detoxnow.com. We'll also empower you with information that you need for what you can do for yourself, as well as, hey, if you need to talk to Dr. P, you need to talk to Dr. P tomorrow. Like, that's what we do. That's why we do what we do, so that you have all the options available to you. All, not just okay, the UFE that somebody's pushing on you, but something that you may not have thought about is a real consideration, because all we want to do is see you have long-term success. And
Facts.
on that note, I think we'll end. Thank you so much, Dr. P. Appreciate you, man.
All right. Appreciate you. God bless
Yeah.
everybody. Y'all be safe.
Yeah, be safe,
All right.
everybody. So friends, family, friends that are our family, we appreciate you. Man, I can't tell you enough, how much that we're committed to this, committed to being with you and committing to supporting you. All right. We'll put this information on the feed, and whatever you need, know that our team is here to support you. If you're dealing with heavy cycles, you're dealing with hormonal imbalance, you're dealing with heavy periods, which is not normal. you're dealing with fibroids or endometriosis, whatever support you're looking for, or you're looking to just make a lifestyle change so you don't end up prevention, and so you don't end up in the scenarios, please take the quiz, the free quiz at the link in my bio at the Detox Now, specifically at thedetoxnow.com. So take the free quiz at thedetoxnow.com so that you can receive our recommendations as well as access to the support community that we've developed specifically to empower you to know better, do better, so that you can live better. All right. You deserve abundant health, and we're here to help you have it. Goodbye.